Joe, I've asked you to unmute yourself, so if you would do that, that would be
Oh,
great.
okay, unmute. I've unmuted. Okay, and there's my share screen.
And Christine, you have it on speaker view only, right?
Let's see. Well, I have share screen and it says host disabled participant screen sharing.
Oh, hold on one sec.
Try it again. Okay, I have my, can you hear me?
Yes.
Okay, and here comes my presentation. We share, and we go to the first link screen. There we go. Okay, now I'm gonna get rid of some faces. Let me just do that so I can see. Okay. Well, we're back one, so let me go up. Okay, here we are. Are we ready? I'm ready. Okay, can you all hear me? Well, I hope so. All right, so this is Joe Murphy. This is who I am. As Sherry mentioned, I'm in Glenwood. We've been here 21 years. And that was when I particularly got interested in the Medicare work. So I've been specializing in it, but I do other health and life type products. So long-term care insurance and other life insurance and annuity products. I've been, brokering those as well. And my consultations are always free, always. If something results in a sale, the company that is successful with the insurance sale pays me a commission. So no one ever has to pay me anything. Okay, so here there are 62 million individuals currently subscribing. As of 2020, that was the number. Actually, it was 62.3 million that are buying a Medicare product, a Medicare insurance product. So you may be ready to come into Medicare, or you're already in Medicare. You have this wonderful red, white, and blue card. And the important data on the card is your hospital eligibility date, Part A. That covers inpatient services that are medically necessary. That's an important point, and we may work a little bit on understanding that medically necessary piece. And the Part B eligibility is for covering outpatient services. So that would be doctor's visits, imaging, laboratory, outpatient surgery, anything that's outside of the hospital inpatient environment. You could still go to a Paoli hospital and do outpatient things, as many of us probably have done lab work, outpatient lab work. Okay. You probably know this, Medicare Part A is free for most of us. You find a rare situation where someone might have come into the country legally and get citizenship and they haven't yet worked, earned their Part A eligibility, but you can buy it. But most of us are getting it for free. Nice thing is a spouse gets it for free as long as the husband has earned his quarters, his 40 quarters or 10 years equivalent. Medicare Part B, we're all paying for that. And it starts at $148.50 a month this year in 2021. And you can pay more. It varies with income. And I do have that schedule of income. If we may get to that point, but right now it's we're all paying for Medicare Part B. A lot of us have it come out of our Social Security check, the account monthly, but we can pay directly if we want. So here's a health profile of seniors, and it's well sourced from the American Hospital Group and another national group. And this really holds up. My own personal experience in these 21 years. Statistically, I don't think anyone's going to challenge this. Statistically, our health deteriorates with age. At age 65, most of us have one chronic condition. That could be blood pressure, it could be cholesterol. At 75, most of us have two. We might have both, blood pressure and cholesterol. God forbid, we might have something more serious. At age 85, most of us have 3 or more chronic conditions. So this is the real world. There are exceptions. Christine, I think her mom or somebody I was recently talking to, a 94-year-old woman, takes no meds, has no chronic conditions. God bless her. But here's the profile that really bears to, I see it every day. 100% of us in this environment, have some lockdown stress. I just thought I'd put that in there. That won't be challenged. But then 58% of seniors have high blood pressure, and on down the list. So now, these 16 specialty departments that we'll find in a top tier hospital, these 16 specialty departments provide the medically necessary services for us. And this is the order in which, unfortunately, mortality is rated. So cardiology department sees the most deaths when all is said and done. Cancer next, pulmonology, that'd be COPD, things like that. Diabetes on down the list. So these 16 specialty departments really are the measure of a really good hospital. And we'll get to that as well. We want to be associated with a hospital that has these departments, or a network of hospitals that would accomplish these specialties. Okay. So there are 2 Medicare solutions. When we get that Medicare card, we can go one of 2 ways. We can buy into original Medicare, which came on the books in 1965, and we typically add a Medigap plan and a standalone drug plan. Now, I have a note that when I say Medigap, it's equivalent to Medicare supplement. It was more or less renamed. It started off being known as the Medigap plan because it covered the gaps that original Medicare Part A and Part B didn't cover. So those gaps are still there, and Medigap plans or Medicare supplement plans cover that. And then we add a standalone drug plan. So that's the one path. And the second path is you would go with a Medicare Advantage plan that came on the books in 1997. So it's also interchangeably known as MA. I might have a slide that just talks about MA, meaning Medicare Advantage. And then one version of Medicare Advantage is that with a drug plan, and we add the PD, meaning prescription drug. So MAPD. So that's it for the definitions. To put you all at ease, both Medicare solutions, that's the original Medicare solution or the Medicare Advantage solution, I'm happy to say they cover COVID-19 tests if you have a prescription. They cover COVID-19 vaccines, and they cover these telehealth virtual visits. So that's good. So, that's not a part of your decision tree. You're going to be sure they're both, either way you go, you'll have this coverage. So let's look at original Medicare solution. It came on the books in 1965. Part A and Part B, Medicare Part A and Medicare Part B are the foundation. This is an important point. Medicare here is primary. When you see a doctor or you go to the hospital, they submit your charges to Medicare, to CMS, the Center for Medicare. So that's important. Medicare is primary. And Center for Medicare, CMS, defines and mandates all the Medigap plans, all the plans that we're going to talk about that cover the gaps, which are now Medicare supplement plans. Okay, so we're there. So this original Medicare product, if you select it, you have access to the entire USA national Medicare network. You have access to it. 718,000 Medicare doctors. You can be sure there's going to be a top doctor in each of those specialties if you need it. 718,000 Medicare doctors certainly cover all those specialties in many of each type. And there are 6,023 Medicare hospitals in the national network that if you go with the original Medicare solution. And this is important. 407 of them have 5-star ratings. And that means they definitely cover those 16 departments, specialty departments. There's another 1,136 hospitals that are 4-star, and it goes down to 1-star. And that's important that we pay attention to, the quality of the hospital system that we're going to, make a commitment to be in. So with this original Medicare solution, most people will then pick a Medigap plan to cover the gaps. And so there are 60 competing Medigap insurers approved by CMS, that's Medicare, okay? All 60 Medigap insurers offer Plan N, and these are mandated to be identical. So if you have 60 insurers offering Plan N, we know they're the same. So we look at price. That's going to be part of your decision making. Why not go with the lowest bidder, so to speak? All 60 Medigap insurers offering Plan G are mandated identical. This is really important. So we'll see how that plays out. At the same time, there are 30 competing Part D drug plans. Medicare Part D is that standalone drug plan that would complement this original Medicare solution. And this is important. It's customized to your specific drug. So, I have software, and it's available to you as well, where you put in the exact drugs that you're using, the dosages and the frequency. These are the very specific drugs that you use, and the software points to one of these 30 competing drug plans. It optimizes the solution. It customizes the solution. This is, I think, outstanding. So the Medicare Advantage solution, which is the second option, it came on the books in 1997. It has the same Part A and Part B as the foundation. So you have to have Medicare Part A and Part B to do this solution, to go with this solution, or to go with the original Medicare solution. Major difference here is the private carrier is primary. Who is that private carrier? It could be Independence Blue Cross, could be Aetna, could be Cigna, could be Humana, etc. And the important thing is they do not have CMS defined plans nor CMS mandated plans. Each of these carriers roll their own. So this is what makes it difficult for all of us to understand which plan has the value that we're looking for. It's incredible what you have to go through. I really sympathize with you. The other distinguishing characteristic here is that none of these have national networks. Every one of them has a limited local network. Now you can go outside of the network if you have the preferred provider organization part of Medicare Advantage. Medicare Advantage has two main, I'll say, products. The HMO product, Health Maintenance Organization, HMO product, where you can only use the limited local network, or the PPO, Preferred Provider Organization option, where you can go out of network. But in all events, to save money, you have to use the limited local network to get the better pricing. That's for the HMO as well as the PPO. So there's a definition of what these networks are. A broad network will have 2,748 doctors and 48 hospitals. This is a national statistic. A medium network will have 1,300 doctors and 22 hospitals. The small network will have 516 doctors and 13 hospitals. So you're hopeful to find your preferred doctor for the specialty you need and your preferred hospital in the network. You've got to sort it out, find them. I mean, it's a lot of work. So there are 9 Medicare Advantage insurers in our zip code 19380 that are offering 55 plans that are all rolled very differently. Every single one is different. There's not 2 that are alike. So you've got to figure out which one satisfies your specific doctor needs, your hospital preferences, et cetera, and we'll get to that. And another important point, the if the MAPD, which includes prescription drug, that's available and it's with these plans. But what happens when you pick a plan, you don't get to tell them what your drugs are. It just says, here is our drug solution. It's captive and it's not customized. So, you just don't have any sense of it being optimized like the original Medicare solution, where those 30 plans are become uniquely matching to your specific drugs. Here, when you pick a Medicare Advantage with a prescription drug coverage, it's just captive and not customized. That can be a problem. So here are the two together. It's the same information side by side. Not going to walk through it. We already did it, but I'm thinking that Sherry might provide you these slides and you can certainly then study them. Okay, so another way of presenting the two solutions, I'll lead off with the Medicare Advantage HMO or PPO solution, and it's the same information, another way to look at it. There are 9 private insurers that bundle that Part A and Part B, which is the foundational piece. They bundle the A and the B into 55 very different Medicare Advantage plans, all having limited local networks. All right. On my right are the 9 insurers that are doing this work. And Aetna, you probably don't know Allwell. Health Partners, you probably don't know. Lasso, you probably don't know. But they are the 9 approved, Pennsylvania approved insurers that are bundling together in total 55 very different plans. And the point I make up here again is the optional drug plan. If you pick an MA with a prescription drug included, it's going to be captive with no competition or customization. And then I like to say the cherry on the top is what you hear from Joe Namath and these television ads, like, maybe you'll qualify for, and now let me get to that. Okay. Maybe your doctor is in the plan. There are 55 different plans. You've got to figure out if your doctor is in that plan, the doctor that you prefer, the doctors. Maybe your top specialist is in that plan. Maybe your hospital is in the plan. Maybe your drug is covered. Maybe referrals are needed. These are so true, these maybes. You absolutely have to talk to the people. You can't just read their directories. Directories can be 2 years out, obsolete. I hear that there are doctors mentioned in directories who have left the plan, 2 years ago. So you have to call the particular plan, one of the 55, to learn all these answers. Are they in? Are they not? Maybe you will qualify for home meals. Now you check this out, and in some of these plans, you have to be in a rural community. You have to be homebound. All right. I mean, that's the qualifier, but it may not have it at all. You may be qualifying for transportation. And again, you have to ask and find out what's the deal. Maybe you qualify for hearing aids. Maybe you qualify for vision and dental care. Maybe foreign emergency care is covered. That's a biggie. When you travel out of the country, is emergency care covered? Well, generally it's not. Maybe the out-of-network reimbursement is accepted. I mentioned that with a PPO, you can go out of network, but the doctor you would go to does not have to accept the Medicare Advantage reimbursement. Doesn't have to accept you. I mean, all of these maybes are there. All right. So coming back to original Medicare solution, the A and the B are the primary foundation, and it's the primary coverage. We have 60 competing insurers with that Medigap solution, and the identical plans at the plan N level or the plan G level, and we may get to that. What's the difference? They're identical across the 60 competing insurers. And we have a customized drug solution where there are 30 competing plans. So no maybes. There are no maybes with 718,000 Medicare doctors and specialists. You will have access without question to the top docs and the top specialists, and no maybes with the top hospitals. All right. So to make a sound decision, there are two steps as I see it. You choose the highest quality Medicare insurance solution that statistically assures the best medical outcomes. Because this is what it's all about, right? If we get sick, really sick, we want to be cured. We want to be healed. We want to know the right diagnosis. We want to know how to get, through it all. That may call for a procedure. And so we want to choose a plan, an insurance solution that's going to statistically assure the best medical outcomes. And the second part of that is while being conscious of the chosen plan's total annual cost. So that's how to break it down. With respect to step one, a health plan is only as strong as its providers. Your plan's network of providers, that'd be the doctors, specialists, hospitals, other facilities, they should have top docs in all specialties to assure the best possible outcome of a diagnosis or a procedure. We want it in a timely manner, of course, and at an affordable cost. And really, you want to have multiple 5-star and 4-star hospitals in that solution, the one you pick. So they can be there in either solution, but you have to, the burden is on you to make sure they are. Now, this is an interesting slide that comes from Medicare. The blue column is for a 5-star hospital that has all the specialties versus a 1-star. And for a given condition, there's a 50% lower mortality rate. It's 6.6% of their procedures, they'd lose the individual. Okay. Whereas in a 1-star, 10.2% will be lost. They'll die. Now, admittedly, they're quite ill. They got a serious situation, but I like going to a 5-star where they're going to, get the job done because they have the skill level. That's the key. It's just using the top docs and the like, the top anesthesiologist, the top whatever, and then we're going to, come out of it with a better outcome. I think that's a good picture. So here's the skinny on Medicare networks. All right. The original Medicare network that includes the entire USA, you've got all 718,000 doctors in that network. That's just real simple, just picking Medicare Part A and Part B. And then if you add a supplement, you've got, you have these 718, even if you don't have the supplement. That's just because Medicare is primary in this case. Best outcomes? Absolutely. I mean, that's your best chance. You're absolutely, the odds are in your favor when you have access to the best of everybody, the best doctors, the best specialists, the best facilities. The Medicare Advantage, here's where I'm using MA, Medicare Advantage networks are limited local networks. All right, so there's the broad, the medium, the small, we hit this earlier, but the broad, we have some broad networks here in our area, and the outcome is going to be likely a good outcome. But you go to a medium-sized network, it's less likely. And if you go to the small, it's least likely. I mean, it's just statistical. So now let's look at the hospital picture. Again, with original Medicare, you have access to all 6,023 hospitals, 407 or 5-star, 1,136 or 4-star. Best outcome, absolutely, statistically, understand. And then it goes, if we go to the Medicare world, there's the broad network. Best outcome is likely. And we have 48 hospitals, 2 5-star and 4, typically 4 4-star. So, and it gets, less likely and least likely. Now, this is helpful. US News puts out a best hospitals honor roll each year. And so I consulted that for this year, 2020 to 2021. They published it in late February. So this is back to, picking a hospital system that best addresses the specialty's name. So for cardiology, The Cleveland Clinic is number one. Mayo Clinic in Minneapolis is number two. If you're, if you desperately want to survive a cardiology issue, I'd suggest you get on a plane or drive to Cleveland or get on a plane and go to the Mayo Clinic. I mean, these are number one and number two, and they have number three. I just am showing number one and number two. If it's cancer, it is an interesting story. I have a client who lives in Hershey's Mill. He was diagnosed with stage 4 prostate cancer. He went to Penn. Penn said, we're good, but there's the people at Anderson Clinic in Houston have a cocktail that is saving lives. He's been going there now for 10 years and he's surviving stage 4 prostate cancer. So, he has Medicare, original Medicare with a supplement and covered all his costs. Pulmonology, you would go to Mayo Clinic, diabetes, etc. I have another client that here, and he had such severe spinal issues that he went to the hospital for surgery in New York, which is again rated number one. And they did spinal surgery on him, and I wound up playing 10 years of tennis with him. I mean, he couldn't move when he went, and he got the surgery. So this is important that you have access to these top docs, top hospital systems. So this is the rest of the list. I have another couple clients that have gone to Hopkins and Mayo. The one that went to Mayo was told by Penn and Jeff that she had Lou Gehrig's disease. And that was terrible news. Her son, who is a doctor, said, "Mom, you get out to Mayo Clinic." At the time, they were number one in this category. And for 2020 to 2021, they slipped a little bit. She went out there, and after 4 days of testing, they said, "This is not Lou Gehrig's disease. We know what it is. We have a medication for it." She has never needed to go back, and she's skipping and doing all the things she wants to do. She didn't get the death sentence. So there's the rest of the list. All right. So this honor roll, basically, you get on the honor roll by having a strong position in those 16 specialties, and Mayo Clinic comes out number one, Cleveland Clinic, and I'm happy to show that Penn, the HUP hospitals of the University of Penn, make the honor roll. They have, I think most of us know how strong they are. They have, excellent representation in all the specialties. So I'd say you want Penn to be in your network. It will be if you choose original Medicare. You want to make sure it is if you choose the Medicare Advantage solution. So the second step was, being conscious of the total annual cost exposure. So we've worked the best medical outcome solution. I mean, I think we paid proper attention to that. Now let's look at costs. All right, so here's the individual that says, "Joe, I do not see any doctors. I don't have any issues. I don't even take any meds. And I'm just 65. It doesn't matter. You could be any age if you're saying that. So I would say, all right, let's look at a Medicare Advantage with prescription drug. That's the MAPD. And let's pick a PPO because it's going to be zero. There are plans in that 55 plans. There are several that are zero monthly premium. So, okay, pick the PPO. It'll cover things that you might need, but you're not using anything. So, I can project a budget for you that it's going to cost nothing for your premium. You'll have no cost sharing because you're not going to do anything. So your budget's zero, like that. And that's obviously why people will go this route. They'll be drawn to this. They'll be attracted to this. Okay. Well, let's look at the best I can do if I put you in an original Medicare supplement product. Okay, age 65, female, married. There's a distinction between married and single. There are household discounts. You don't have to you could have a partner, you could have a sibling, as long as they're an adult. Some of these just require an adult in residence. So married or perhaps another resident, and you qualify for a household discount. But so this is my best rate for someone age 65 with Plan N, and it's going to be $87.78 a month, which totals $1,053.36. You won't, because you're not the same person here. We're not going to any doctors. We're not getting any services, so there'll be nothing. You won't be charged for anything. There's a $203 per year of Part B deductible that you're not going to be participating in. But I'd say get in a drug plan. We have a drug plan that's $7.30 a month. And so here's your budget. You're looking at $1,149 a year if you're married. If you're single, we take away some of the discount. So you have a budget of $95.78 a month, or $102.39 a month. That's married versus single. So, if this person was absolutely sure they would not come down with anything that called for doctoring or a hospital or meds, I'd say go on the right. Go with the but that's a tough one to say, because the next day something comes down the pike, something like the coronavirus. So that's a minimum situation. So you'd have to say, I know I'm not going to get sick. I'm not going to need any medical services, and I'm going to go for the $0 a month solution. And the caveat there is, what happens if you get sick? So let's look at that situation. So the maximum, the flip side here, is someone with chronic medical conditions. I'll stay with the age 65, but again, pricing is on the Advantage. When we go to Medicare Advantage, the pricing is not age specific. So this could be a 95-year-old female. And I'm going to put her in a PPO, a Medicare Advantage with prescription drug. 12 months of premium at $0 a month is zero. But now this is where these ads don't own up to what your exposure is. When you go into a PPO and you do go out of network to get a top specialist, your exposure is $11,300 per year before they pay 100%. Some PPOs, they have a maximum out-of-pocket max of $10,000. So, of these 55 plans, a bunch of them are going to want you to spend $11,300. When you get sick, you could conceivably go to the hospital 5 times and have 5 different hospital stays. You could, just see a lot of doctors, and it just gets up there to $11,300 or $10,000. At the same time, a plan that has a $0, this is the bait, the $0 per month premium that, is very attractive. But if you read the fine print, there's a medical deductible of $1,500. Some are $500, some are $0, but there is one that you could pick without doing your homework that would set you up for spending $1,500 before they pay anything. And then you still have to pay the $11,300 or $10,000 before they pay 100%. 67 a month. You take that 1,066.67 per month, which is the combination of, if you take 11,300 and divide by 12, that's 941.67. You take the 1,500 and divide by 12, that's 125. So that's 1,000. So do you like $1,066.67 a month? That's if you're looking at 11,300 as your out-of-pocket max, or you could be at 958.33, which is 833.33 a month, which is 10,000 divided by 12. And the 125 is that medical deductible divided by 12. A lot of math here. I might mention that my degree from college, 5 female. Now I'm going to put her in Plan G, because her only exposure is going to be this $203 of Part B deductible. I'm going to assume she easily uses that up because she has issues. She has medical issues. So I'm going to put her in G. She's going to pay $124.72 a month. She's going to get, absorb the $203 of the Part B deductible, and that's it. No other copays, no other deductibles. hospital, whatever. She could go to the hospital 5 times and not have any charges. And she's going to pay $8 a month in that drug plan. So her total, $1795.64 if she's married, because she gets a household discount, or $1908 if she's single. So we now have a budget. This individual, very sick, potentially very sick, is looking at $149.64 a month or $159.02, but that's it. Can't be any more. Okay, so let's compare them. So what do you like here? This is someone that is either very sick now or could potentially be very sick, might look at her family history and know that, at age 66, 67, dad got this, mom got that. So she wants to be prepared. So I'd strongly recommend that she goes on this side, 149.64. We're going to get a better, we have the best outcome situation with us versus 1,066. And it doesn't happen monthly over here. You could just get a $6,000 bill in a given month, but you'll top out at 11,300 or 10,000 plus the 1,500. It's a lot of numbers. Apologize, but that's the way to look at it. All right, so we've looked at quality and we've looked at cost, and these are additional requirements for delivering high quality healthcare, highest quality. Whoops, I went the wrong way, sorry. You'd like the plan to be evergreen. Now that means that it continues year to year, guaranteed to be renewable, independent of your health. You want to get into a plan and know it can't be taken away. It's not going to go away. It's guaranteed to be renewed every year. Well, that doesn't happen with the Medicare Advantage plans. They automatically terminate on December 31st of every year. Whatever plan you're in, it absolutely automatically terminates on 12/31, and you have to do an annual renewal, re-enrollment. So the people are saying, I'd like a plan to be evergreen. I don't want an automatic termination, and I don't want to do an annual re-enrollment. I don't want referrals required to see these specialists or doctors. I'd like to have, if I need a third opinion, a fourth opinion, a fifth opinion, I want to be able to do that without referrals. And again, these are things you cannot do with a Medicare Advantage plan, but you can do if you're in the original Medicare side. A couple more. You want your plan to be usable throughout the USA, facilitating non-emergency scheduled visits. Okay, let's unpack that. You can't do that with the Medicare Advantage product. This is out of the network. You're out of the local network, and you're trying to schedule a visit. It's got to be emergency, and then you can get help. But this portability of your plan, this is really nice. We've talked about budgeting, and you can budget. I think you definitely can budget in a better way with original Medicare. Sherry and I talked about this, foreign travel. Now this is really nice. I've had several clients who went out of the country, and if in the first 60 days you have an emergency, it will be covered at the 80% rate after a $250 deductible, and then it will be covered at the 80% rate up to $50,000 lifetime. This is really nice. You don't have this with the Medicare Advantage products, but foreign travel emergency coverage is really there. And I've had a person from Inverness that went to Bermuda. She was on a cruise ship out of Fort Lauderdale, became deathly ill. They put her in the sick bay. When she got to Bermuda, they put her in a hospital. She had pretty severe pneumonia. And, so they worked her through that, got her stable, let her go home. All they wanted was her credit card. And when she came home, she called me, and I was able to say, yes, you're going to be covered. It was a $14,000 credit card bill, potentially, but she got 80% of that covered. It was really nice. Another friend went to Ireland, of all days, to speak of Ireland. She went to Dublin. That was on her bucket list. She got quite ill. She really did. She stayed like 6 weeks in a Dublin hospital in a ward, mind you, not in a private room, and she loved it. She said the doctors and nurses couldn't have been nicer, but as they got her through the situation, her bill was $40-some thousand, and we got 80% of that back for her. I mean, this is really nice. Another person went to Spain, got quite ill, and he was able to get help, get some financial help. You can buy travel insurance, but this is different. This is through Medicare. This is through the Medicare supplement product, actually. So that's original Medicare with the supplement, and you can get this coverage. It's there for all their products, all the original Medicare extended products. So we're almost finished. 62% of eligible seniors choose the original Medicare solution because all of those high quality requirements are in place, and because total annual cost exposure is always lower for seriously ill seniors. Fact. Now, right now, we're in a period called the Medicare Advantage open enrollment period. It runs through March 31st. We have, 13 days remaining. It was previously known as the Medicare Advantage buyer's remorse period, meaning you're in Medicare Advantage and you realize it's not working. You have some significant exposure and you'd like to get out. So now through March 31, you can make a move. It's known as the MAOEP, and it permits you to disenroll from a Medicare Advantage plan if you want to, and concurrently enroll in original Medicare as your primary, adding a supplement and a standalone prescription drug plan. That's one thing you can do, but you can also do this. You can look at the 55 plans, Medicare Advantage plans, and it permits a carrier change, an insurer change among the Medicare Advantage insurers or carriers. So you can do one of two things: walk away from Medicare Advantage and go into original Medicare, or find a better Medicare Advantage plan, a different insurer, different plan, whatever. Let me just quickly on this. So medically necessary is where we've been. All of these plans are addressing medically necessary medical services. They are acute in nature, calling for skilled care. So Medicare does, this is, people misunderstand this. This is the number one myth in misunderstanding. Medicare people, a lot of Medicare people and their children believe that Medicare will cover long-term care services, but it doesn't. Medicare does not cover long-term care services because they are custodial in nature. They are not acute. They're custodial, and meaning room and board, housekeeping, meal preparation. Those things are custodial. But a lot of people are misguided, thinking that their Medicare will cover long-term care insurance. So that, I think, is an important point. Resources for you are 1-800-MEDICARE, www.medicare.gov, Medicare and You. That handbook is outstanding. It truly is. And then, or myself, come to me. You're very welcome. I have a phone number and an email address. And that's it. Thanks for watching and listening. And, questions could address, other Medicare supplement plan types, competitive pricing, Medicare Advantage, deductibles and copays, Medicare Part D prescription drug plan review, etc. That's it. How do we come back? How do we get back? I'm finished, Sherry. Well, I'm finished with my presentation.
Joe?
Yes.
Bob Zink here, Joe.
Hey, Bob.
How are you? Do you handle long-term care insurance?
Yes, yes.
You do? Okay.
Yes. Yes, I do.
Yeah, they're getting expensive now. I've had one for a while, and I just got a notice of a 44% increase in premium over the next 2 years.
Right. That's right. Yeah, there's only one well, there were like 60 long-term care carriers, insurance companies. We're down to about 5 or 6 of the
Yeah,
high quality carriers.
right, right.
It's, yeah, they're not happy with their policies that people have, and the people aren't happy. So they've had to raise prices. Okay.
Well, I'm happy with the policy. It's just getting pretty expensive, but
Sure. Sherry, are you there?
I am here and I've asked everyone to unmute themselves
Okay.
so that they can ask any
How can we
questions.
go back to pictures, or do now I have slides that I might turn to for answers. So maybe I should keep the
Sure.
PowerPoint situation.
Absolutely, just leave it up.
Okay.
Joe, can I ask one more question about long-term care?
Okay.
I actually been paying into long-term care. I got it really early, like 14 years ago or 15 years ago. So I've been paying it a long time and it's a lot of money. But, the policy, I think, if I never use it, no money ever gets back to my beneficiary. Is that how they all work?
Well, that's how most of them did work. And in the last 4 or 5 years, the insurance companies realizing that's hurting them, it was use it or lose it, right? Use the benefit or lose it. The premiums that you've paid, you would lose. But I have maybe 4 insurance companies that have addressed that by saying, how would you like a full return of premium if you don't use your benefits? Well, sure, that's one answer. Another is, what would you like a death benefit? The individual never gets to really need long-term care coverage, but will die. And so why not have a death benefit comparable to life insurance? So these are insurance companies, and they're smart people, and they've really addressed those major complaints. And the big one was use it or lose it. And they have addressed that with, you can cash out, like a life insurance policy. If you have cash value and you say, you know what, I'm not going to need it, the children are married and our mortgage is paid, why don't I just cash out and take cash? So those are the 3 options that the more resourceful insurance companies have introduced with their product. Now, you can't add that to an existing policy.
That was can I switch to something else, or this is what you're locked into? There's no changes.
Sherry's the groundkeeper or the rules keeper. I don't know. I do this work every day, long-term care as well as Medicare. So,
Hey, Joe.
Yes.
Joe, I think, hold on, let's finish that. I think what she's asking is, if she's got a long-term care policy that does not allow any returns to the beneficiary, is she locked into that particular policy, or is there an opportunity for her to change?
well, there is an opportunity to change, but now we're faced with full underwriting. I actually have 2 long-term care policies. I wanted to top up. I call it top up. I wanted to add another $100 a day as, medical pricing for long-term care. Well, for, skilled nursing got to be at the $400 a day level. I was going to be underinsured, and I added, so I topped up. You can top up, and as you might top up, you would pick, those benefits. You would say, okay, I'm going to now add some benefit, but I want also the return of premium option, or I want, the cash benefit option, or whatever. But you can't change what you have. If you stay with it, that's it. You can drop it, but you don't want to drop it without replacing it. But there's no modification. I'd like to change my first policy to a certain extent. I can reduce benefits. But I can't add benefits.
Well, Joe, I think your point, maybe one of your points is, if you drop what you have and you sign up for another one, if you've had the one for a while, it's going to be a lot lot more
Absolutely. Yeah, it's not economical.
Right.
To have that thought. I mean, if you're 50, 55, yes. If you're 75, 80, no. The pricing is off the charts. I'm embarrassed by the pricing. I mean, long-term care, it's sticker shock.
Let me tell you a little story, Joe. We had years ago, and I don't know how much they've changed since then, but we put a a plan in place for the pastor and his wife at our church. And we chose the option of getting all the premiums back at the end, when they both die.
Sure.
And it was like 40% more premium. I think
Oh,
that's about
sure.
right.
Oh, sure.
However, it's going to be a tremendous nest egg when the church gets that money back.
Exactly.
When he goes, I mean, it's going to be huge.
That's
So,
right. If you can afford the higher premium, to add those features, like can almost double premium, but you're going to get it. Your estate is going to get it all back.
right.
But you have to be able to afford it. You have to. So now
That's
they've gotten quite resourceful in how do you fund. You can take life insurance policies and do an internal transfer. It's called a 1035 exchange. I mean, so they've done lots of things. I mean, it's still money, but it's more money usually. But they've found ways to move a life insurance policy directly into a long-term care policy and looks like a life insurance policy where you can get the death benefit or a cash out option or return of premium. So yeah, but it's more expensive. But the sweet spot for a new sale is typically someone certainly under 70. I mean, it's ideally 50. I sold to my son and my daughter, who are in their 40s, and they've got a great policy, but they don't have return of premium because it wasn't available when I sold it to them. But they have, fantastic policies at an attractive rate. Where are we? That's long-term care.
Two questions on the N and G policies.
Sure.
Under the donut hole.
Mhm.
Why, if it's all exactly the same from company to company, do prices vary from company to company on N and G?
Okay. Can you see this slide?
Yeah.
Okay. The CMS, the Center for Medicare and Medicaid, they define Plan N and they define Plan G. They define Plan A, Plan B, Plan C, Plan F, but the ones that are relevant for us are N and G. And so all 60 insurers have been mandated. They must be the same delivered benefits. So we don't have to go into the fine print and say, well, how do you differ Mr. Aetna versus Mr. Cigna, Mr. Humana, et cetera. All Plan N's are the same, all Plan G's. Plan G is richer, in my opinion. It has only one annual deductible of $203. Plan N, now you asked, why would they price differently? They're not held to price. They're only held to deliverables. The benefits must be identical, but there's no oversight on price. If they price themselves out of the market, I'm not going to, no one wants them. Why would you want to pay more for the same identical product from, a different vendor? If the quality of the vendor is excellent, and then we get ratings. I have access to how they're seen in the industry by AM Best and Company. So let's say out of the 60 insurers that are offering Plan N and Plan G, I like maybe 15 of them. They're rated excellent. So I look at the first 15 and I go for the lowest price. So actually, I have another, excuse me.
I guess the question was, why do they vary in price?
Because marketing, if you were directing their marketing, you'd say low price is going to win the day. So, so you say, okay, my advertising is going to offset some higher pricing. That's how AARP and United Healthcare get market share. They just inundate us with ads, and they command the most money of all the 60. I mean, they're always the high price. So you have to say, how good is your marketing, and I can command a higher price. If you don't intend to do national advertising, you got to have a lower price to get the business. So none of them are held to pricing levels. There's no oversight on price. The government, their mandate is you must adhere to our definition of what Plan N is. It has to be identical. So,
well, I suspect, Joe, that the reason that there are a lot fewer of these companies offering this product than there were 20 years ago when I bought
Well, that's
mine.
long-term care, Bob. You're just, we're talking Medicare. This,
I
the question
understand.
addressed Medicare.
No, I understand that, but on these Plan Ns and Plan Gs are from the private insurance companies, right?
Yes.
And I suspect that a lot of them that did this years ago have taken a bath in losses, and that's why there's only however many left that you said there are.
No. I was talking about the life insurance companies that were selling long-term care insurance.
I know. Yeah.
The number of companies selling Medicare insurance has grown. We have 60 in the Pennsylvania marketplace. We had, maybe when I started, there might have been 30. So
Yeah, you're right. I'm sorry. I was thinking of the long-term health care.
Right, the long-term care.
Right. Yeah, forget what I said.
Yeah. So we're talking, there are more companies competing for the Medicare supplement business, and I love it because they're under price pressure.
Yeah.
If you were a new guy on the block, how are you going to get the sale if you don't have a good price? You got to have a competitive price. But if you've been in the marketplace for 30, 40 years, and you run those ads and send out that paper, those ads and the printed paper, you're going to say, we can command maybe an extra 10%. So pricing is, I love the competitiveness of the Medicare supplement products. Absolutely.
And my next question in connection with that is, when can they change the prices? I have United, and the coupons run to May, and then I'm getting new coupons. Can they increase the prices in May for coverage?
Yes. This is interesting. Most of them in their contract, when you look at you look at your printed contract with United Health or AARP, as you might, most of them will say, we are protecting price. When I close a sale, most of my carriers, except AARP, United Health, will protect price, lock it in for 12 months. So the first price that you sign up for is going to be good for 12 months. And then on an age basis, it tends to change. So when you have a birthday in the intervening year, you're looking at an increase. Here's, we're showing from 67 to 68, there's a $4, not quite $4 annual increase. So you can expect the annual increase to happen. But AARP only guarantees lock in for 6 months. All these little things make a difference, but most people don't know that. I do. I want 12 months protection on a price. If someone says, I'm ready to go forward at $105.50 a month, they want to know that they can budget that for, the 12 months. Then we're looking at a new price, which is typically $3 or $4 more because of age. And then they can introduce pricing associated with the cost of medical care in the country nationally. So typically you'll get that letter saying, effective May 1, your new premium will be X, and it's a factor of an age. You've added a year of age, but that wouldn't necessarily be true with AARP. But it is certainly.
I have a question for you. Do you also choose companies, based on how well they pay or how well they work with the hospitals? Are they rated a certain way, these companies?
Yeah, they get 1 through 5 stars.
Okay.
As a plan based on customer feedback.
Okay.
So, you can consciously, that's another part of the equation. I like to see them being rated excellent for their financials, long-term and short-term. That's from AM Best. I get that data. And then CMS provides 5 stars through 1. So that's another piece of it. But I favor the AM Best rating. And I've never had a complaint about one of these companies you've never heard of, who are in this mix of 60, not paying their bill, not paying the reimbursement that the contract calls for. I've never had an issue, never. So they're approved. See, they get on the list of approved when your insurance commissioner in Pennsylvania it looks at the data and looks at, are they satisfying CMS, et cetera, and then they put them on the approved list. So I've not had any issues on, say, non-compliance.
Okay,
I'll
thank
go
you.
one step further for you, Joe, and support what you said. I had a situation where I had some things done, and I got a bill from the provider for $500, and I said this should be covered. So I called my carrier, the Plan G carrier, and asked them what happened. And she said, "Well, we never got anything from Medicare, so let me follow up on it." So she took the initiative to follow up on it. I didn't have to do anything,
Yeah.
and
Yeah.
it's been all resolved, right?
The way it works, let me just explain how it works. When you go to a provider, be it a doctor or a surgeon, whoever, you're doing outpatient surgery, whatever the issue is, and you have the original Medicare product with a supplement, that provider submits only to Medicare, to CMS. Medicare then has a database that it doesn't get updated instantly, but if you had a carrier change on your supplement, you went from Cigna to Aetna or Aetna to ARP or whatever, it might take 30 days, maybe 60 days for CMS, Medicare, to have an updated database. The new carrier has to provide Medicare with that information. We now have Bob Zink's policy. And so if that doesn't get done, that little link doesn't get followed through, the new guy doesn't ever hear from CMS. CMS passes, so I was back to explaining. So the doctor submits to CMS. CMS says, "Oh, Mr. Jones is also, his supplement is with, let's say, Cigna." And we will send Cigna the notice of the submittal of charges, and we'll let them deal with their contract with Mr. Jones. And it works out. But the database is maintained by CMS, but it has to be updated by the new carrier that now has Mr. Jones as a client. I don't do that. I'm happy to say I don't have to do that. Medicare does a pretty good job, but it could be easily a 1 month lag, possibly a 2 month lag for them to get it sorted out. So that typically the doctor resubmits. He uses that term. You tell their office, "Will resubmit." The database ought to be up to date at this point, and it gets worked out.
Yeah, I think Medicare, of the government services that I deal with, Medicare and Social Security are, in my opinion, the most responsive and the most eager to help. I mean, I've never had a problem with them. They've always been really great. They say they're going to call you back at 10:35. That phone rings at 10:35. It's amazing.
I mean, I think we want, I have to agree, Bob, but I don't think we want is for the government to become the hospital or the doctor.
No.
But yes, let them administer. They're doing a great job of administering this product, the original Medicare product, and they basically administer by defining and mandating the Medicare gap products and also the Medicare Part D product, the pharmacy product. They really do a great job, and I'll say stay with it, leave it that way. Don't go into the hospital business.
Hey, Joe, can I ask you a question here?
Sure.
I appreciate you doing this. This is very informative. I've attended seminars on this topic and walked away with a giant headache, and I just didn't have any clue, but you're making it very clear. I appreciate it.
Oh, thank you.
Now, you mentioned that we're all paying into Part B, but that's assuming you're not still employed, right? I mean, I'm working,
Right.
so I just need Part A.
Oh,
Correct.
true. If you don't need Part B, you're not paying for it. Obviously, you only need Part B when they've cut you loose. Actually, some employer plans or association plans tell the individual, "We expect you to have B because we're going to be primary." But most of these corporate or association plans are saying, "We provide the benefits that are equivalent to B. You don't need to have B."
Right.
So you don't buy it. You don't sign up for it. So you don't pay for it until you actually are enrolled in it.
But would it make sense to compare what I would get from Medicare as opposed to the employer's Part B?
Oh, sure.
Okay.
I rarely, it's a rarity when we have that discussion, because they're assuming, don't we all assume, when I worked for IBM, Bob worked for IBM, like,
Yeah.
well, they're certainly looking after me. I mean, I don't even have to go there, but now and then I'll get someone to say, maybe if I went individual here, left the corporate plan, stayed employed perhaps, but don't take their product, I might do better. I might do better individually, and that's true. But as a rule, the corporate plan, the employer plan is maybe they're participating in the premium.
Yeah,
I see you were playing in the garden. Excuse me? Hello?
I think it was just background noise.
Oh, okay.
I don't know if David's finished, but I
Yeah,
also,
that answers the question. Thanks, Joe.
You're welcome.
Joe, my name's Kathy Munn. I am 68 and I'm still working full time. So I did get the Medicare Part A. I'm covered under my company, but I'm planning on retiring this year. So this is very helpful to learn about the different plans because it's totally overwhelming knowing there's so many companies out there and you just don't know which one to pick. I was a little late coming to this because I got pulled into a meeting, but question, would you be able to share your slides?
Oh, sure.
Okay, that would be helpful.
And we could go one-on-one,
Okay,
I'm learning how to use Zoom.
okay.
And so you and I could go one-on-one. I could be the host, you could be the host, whatever. And
Okay,
we could,
yeah, because I will, hopefully by September, I would like to retire. So I don't even know, like, do you start ahead of time to get the supplemental coverage?
yeah, if you know your date, your
I
separation date,
don't, yeah,
then you can go 90 days in advance and contact Social Security and say, I'd like to have my Part B effective on whatever, 9/1, 8/1, if you
okay.
know your date. And
Yeah, I don't, yeah.
yeah, once you know your date, they need 60 days for you to get a new card. They may get it all done, but you're not going to get a card, your red, white, and blue card that says you're eligible.
This
for-
card, the Medicare card?
Excuse me?
This card, it's the Medicare
Yeah,
card?
yeah. When you talk
Yeah.
to Social Security, they are in charge of sending out the Medicare card.
Okay,
Yeah, you talk to them. You can either visit or go online, and you can actually order your Part B once you know your date. But I recommend do it as early as you know,
okay,
because if they take every bit of 60 days in this environment, they might take even 90. I mean, it's they have limited capability. Yeah,
all right, thanks.
sure.
Can you explain me, it's Suzanne Spitzer, can you hear me?
Yes,
Can you explain to me the difference between N and G
sure.
again?
Sure. Let me actually get a slide that shows us N and G. Let's see. Here we go. Okay. Okay. Can you see the slide?
Yes.
Okay, I'll make the full screen. All right. So Medicare is primary. Yes, for both plans, provider network, the entire USA. So take a look at the only place you have money involved. In other words, you'll pay zero, all right, for all these activities if you're in G. There'll be no deductible for the hospital time, the first 100 days in skilled nursing, on and on and on. In contrast with N of these different services, you could pay up to $50. That's it. It's capped at $50. Not bad. You go to the emergency room. I've seen bills for emergency rooms that are like $2,500, $3,500, and you're capped at $50. It's waived if you're admitted. So you don't even, if you're admitted, you don't want to be admitted these days. You want to go home. But your worst thing, you're going to get the $50 charge. Okay, so let's look at the next slide. The rest of the types of services. So here's the only charge if you have G is the Part B annual deductible. That's if you see a doctor, you go to the specialist, outpatient surgery. Once you absorb the first $203, you're finished. Everything is zero. Whoops. Let me go back. Okay. Whereas with N, You have the same 203. Remember, we had the $50 if you go to the ER. Now we're going to deal with this 203 again. And on an ongoing basis, if you see a doctor, a Medicare doctor, understand, you're capped at $20. It could be 19, it could be 18. Like the podiatrist might charge $90. That'd be 18. You'd wind up with an $18 bill.
Is that each time you go?
Yeah.
Yeah.
Yeah. Mhm. So if people are seeing more than one doctor a month, it pays to go to G. You
Which
get rid
one's
of-
more expensive?
Oh, the G is about $30 more a month
Yeah.
for all ages, for all ages. So the trade-off is if you are committed to seeing your primary, count up the doctors, you're seeing a cardiologist 3 times a year, maybe whatever your issues are. There's a point where G takes away, you don't see these $20, these are recurring charges. Each doctor visit, each specialist visit is capped at $20. So you see 10 specialists or doctors in a year, you're looking at $200. Divide by 12, that's not quite $10. So you'd stay in that, but you don't know. You don't know how many you're going to need. And, who knows? The crystal ball. It's safer to be with G. Of my business, my clients, I should say, it's like a 60-40. They're going to G. 40, I just signed up a couple 65-year-olds and they're healthy as can be. And I said, N is the right plan for you. And they looked at their family history. In other words, it's not likely they're going to come down with something. So stay in N for a while. Thing is, if you are in N and get quite sick and it's chronic, it's not a one-off, but it's chronic and you're going to be faced with that for the rest of your life. Like, let's say type 2 diabetes. You rarely get rid of it. It's progressive. So then you'd like to be in G. Well, what happens here is they hold you here for 2 years. Till you've had a medication that has stabilized you, so I have type 2 diabetics that have had to wait 2 years and then they move over and get their G because they've had a medication that satisfied the insurance company that addresses type 2 diabetes, metformin, glipizide, those kinds of things. And or I've had people with AFib and they go into AFib and that's now a new issue. And we have to wait 2 years for the blood thinner or whatever the prescribed medication is to get that 2 years behind them. So you can get locked into N for a 2-year period or indefinite. If let's say cancer comes along and you don't beat it. Let's say you're struggling with it. It's not declared clean. You're not declared clear of cancer. Then they say, well, we got to wait till you have 2 years of being cancer free. There can be situations, COPD, for example, that doesn't improve. Rarely do people get rid of their COPD. So they get stuck in N. Okay. But so they should be in G. And so I have like 60-40 more people going for G where all they have to deal with. This was $198 last year. It was $188 like 5 years ago. It's creeping up, but it's $203. That's it. That's your only deductible. So on top, so you have your premium to deal with. That's coming every month. And then, at some point you're going to pay the $203. I mean, and you can, go to the best doctors, the best hospitals, whatever. So does that answer that question? I hope so.
Yes, thank you.
G versus N. It's really, if you're healthy, really healthy, let's say you're at 75 and healthy, I'd go to G. If you're 65 and healthy, I'd go to N. It's just that, we know statistically at 75, the statistic says we have 2 or more chronic issues, whether you have them yet. If you're, as I say, I was talking to someone's about their mother who's 94, no meds, no conditions, God bless her. I actually, hello?
And that wasn't me. I don't know who said that.
Joe,
Yeah, that was me. I was unmuted. I'm going to have to leave in a few minutes.
Okay, well,
Okay.
thank you. Thank
Hi,
you.
Joe. This is Michelle Cohen. I came in late. Sorry,
Hi,
I
Michelle.
missed it.
Hi, Michelle.
I'm not quite 65 yet, and I don't know if you've hit this in the very beginning as far as when can you start applying for the Medicare?
90 days before you turn 65 or 90 days before you're already 65 and you're going to get your Part B for the first time. In other words, let's take the first case. You're 64 and you're not employed. You're on your own, and so you're looking forward to Medicare. Give it, within 90 days of your date. Like if you're a June baby, June 1 is your Medicare eligibility date. If you're going to become 65 in June, anytime in June, the first of the month is your eligibility date. So 90 days before June 1, you would want to contact the Social Security office or go online. You can go to medicare.gov and you can actually, order your Part A and your Part B online. But, the office is over there near Panera Bread, near Rite Aid or ShopRite rather, the office for Social Security. I feel better going in. I've taken people in. I took a blind fella in when he was ready, and then you just feel like being a Medicare Part A person working for a company who wants you to have your A, but you don't need your B. But when you need
I will need the B as well because I'm self-employed. So
Okay.
I need to know the plan before I go in to tell them exactly.
No, you don't need to know what Medicare supplement plan you're going to. All you want to tell them is you'll be ready for your A and your B on a certain date.
Oh, okay.
And then all I need, if you were working with me, all I need is 30 days. I mean, we could talk 60 days out. We could
What
talk
village
90
are you in, Joe?
Excuse me?
What village are you in?
Glenwood. So, we can talk 90 days, 60 days, but I need 30 days to turn around an enrollment. Medicare Plan G, Plan N, you might want, well, they've taken away C and F for just a point. Anybody over 65 can still have Plan C and Plan F, but a new 65-year-old, they've taken those two plans away because they had no deductible, no copays, and they felt people were abusing Plan C and Plan F. They'd have, I want another doctor's visit. I want another lab work. And I don't believe people are really abusing that, but they took away C and F from new people, but people over 65 that have had Medicare can continue. I can still sell them C and F, but they're overpriced. I try not to sell them, even where you're eligible. I feel they're overpriced. When we mentioned that a Plan G is typically $30 more a month than a Plan N, that's just typical. Some are 20, some are 20, depends on the company. But Plan F could be $60 more or $70 more, Plan C or F.
Well, I very rarely go to the doctors. I don't take any medicine. So I just hope that everything stays the same.
Yeah.
Joe, you probably have spreadsheets or something. It's just a math exercise to figure out which one's the best for you. And you probably have spreadsheets or can help people do that, right?
I sure do.
Yeah.
Yeah. Well, an example would be, that one I had on the typical, I basically develop a spreadsheet. Where is that one on the different prices? Right here. Like, so, if someone says I'm 75, so I say, okay, male or female, married or not, and we get down to, I show them, okay, another slide, I show them then 4 or 5 different carriers. Yep, that's just like you said. Where was it? I have a slide. I had one that gave that an example, but I don't see it. Oh, well, sorry, don't see it. But yes, yep, definitely. And I'm not to mention, as a point of ethics, when I make a presentation like this, I'm not to present a particular insurance company. It's like, it's to be generic. So I have a slide, and I don't know why I couldn't find it, but it has insurance company number 1 through 6. I show 6 insurance companies and how they vary in price for Plan N for a 68-year-old or a 69-year-old. And they do. They vary, typically the spread is like $40.
Really?
Like this 105.50 for, let's say this is insurance company number 1. That same age group, that price might be $40 more for another at age 65, 67, might be my sixth carrier.
Wow.
Yeah, the spread is you really, yeah, you just have to pay attention. I truly believe, not patting myself on the back, but a broker can really sort through this and guide you. But my guidance is I want a company that is financially secure, short term and long term. And I look at the AM Best rating, and they all have them. So I certainly go with that. I would not sell an AM Best B or B plus. I just go with A plus through A minus. That's AM Best. That's their excellent group. And
Okay, I have one more question.
Sure.
When you become of age and you take your A and B, do you have to take D even if you don't take any medicines?
No, you do not. That's a good question. And
You're not penalized by not taking a drug plan?
well, that's a good question. Oh, by the way, here's that slide I was looking for. But let me just, I misspelled Medicare. I see that. But Bob or whoever was asking, here are 5 carriers. This isn't much of a spread. This is very reasonable, but the most competitive for a female age 70 with a household discount, this was the range. Not bad. But if I went out to 6, 7, 8, 9, 10, or 30, or 60 rather, it easily would be a $40 spread across. Okay, but back to the question of Medicare Part D. Okay, Medicare Part D. Okay, you ask, you're going to be 65 and you'll be eligible, but it's optional. And you said, is there a penalty? Yes, there is, if you want to later come in. So it's optional. And I have, unfortunately, I've got a client who at 80, 15 years now, she's been eligible. And she says, Joe, I don't take any meds. As I mentioned, there's a 94-year-old that doesn't take any. I had a 101-year-old that didn't take any. And so she's ahead of the game. She never bought a plan. But right now, the lowest plan of the 30 in 2021 is $7.30 a month. So I'd say buy that plan. You have no meds, but buy it. And if you need a anti-shingle med, if you need something, you need Tamiflu, it's going to be like $30 instead of $75 because you have a plan. But still, you'd say, I don't want one. Okay, fine. So what happens? The penalty. So this woman who's 80, she's 15 years without a plan, and she now really wants to be in a pharmacy plan because she has some major issues. The penalty for her is roughly $45 a month. It's 30 cents per month that you weren't in when you could have been in. So this woman could have been in at age 65. And so for 30 cents times, I'm saying 15 years is 15 times 12. Yeah, times 15 times 12. That's $54. That's the penalty, $54 per month forever. She's 80. If she lives 10 more years, she's going to pay a surcharge of $54. That's a penalty every month to the plan she'd pick. Now she could pick the plan that's $7.30 a month, but the government's going to add the $54 for every month that she continues to have a plan.
So it's $54 plus the $7?
Yes. Yeah, that $54 surcharge is the penalty that adds to whatever plan she picks. Now, $7.30 is the plan for people that generally just have a couple generics. It might be a $20 plan, or I have a $20 plan, I guess, or a $17 plan. There are 30 plans, and they range from $7.30, that's the lowest a month, to, let's say, $50 a month. And the 50 is based on someone saying, I've got some really aggressive drugs that I need, for some very serious conditions. These are typically brand drugs only. They're not yet generic. And the software still arrives at the best customized plan for that person's drugs. But if it's just $7.30, that's your base, and you add the $54. That's that for the woman that's 15. They're all covered under Medicare Part A while you're in the hospital. So you don't have to have a D. a Part D for that.
Okay.
I mean,
but-
if you really had a good sense that you won't ever, have a chronic issue, that's the game. You can say, I'm not going to go with a Part D, a Medicare Part D.
Mhm. Okay.
Joe?
Yes.
That's Pat McGuinn, and I'd like to have a chance to talk to you, or I wanted to send you an email, and I don't know what your email is.
Oh, sure. It's Joe Murphy, JoeMurphy. Let me find it. Excuse me.
Joe's in the resident directory. He lives in Glenwood.
I am the Joe Murphy INS at Gmail.
Okay, because my circumstances are a little different,
Sure.
so I'd
Oh,
really
yeah.
like a chance to talk to you.